Thank you to those of you already online. We will just wait a few moments longer for those joining us in the live event to log in. Please bear with us for a few moments and we'll start shortly. Okay, I think we can begin. So hello everyone, and on behalf of the United Nations Institute of Training and Research, I would like to offer a warm welcome to all of our participants for this 6th and final episode of our Responsible Digital Health Speaker Series. We've opened many of our webinars in this series so far by framing the upcoming discussion in the context of the 17 Sustainable Development Goals to which all of the United Nations agencies committed in 2015. Of these 17 goals, we're particularly interested today in SDG 3 to ensure healthy lives and promote well-being for all. We heard in last week's session on the challenge of pilotitis that sustainability can be viewed in a number of different ways. And one of these ways is scalability, and in terms of project length, but also of course in terms of its size. So this week we take a look at scaling up innovations for sustainable digital health projects. Scale up is generally seen as a trait of a successful project. It proves that your idea doesn't just work in a specific setting or for a short period of time, but that it can be adapted to have broader value and gather substantial support. In reality, though, few pilots and small projects manage to make it up to scale, and for a number of reasons, which we will learn about in the course of today's discussion. But one way to improve the chances of being able to scale up your project is to make sure that it's designed and built with scale up in mind. And hopefully over the course of this 6-episode series, we've learned what some of these steps are. So today with my guests, we will explore what it takes to design scalable digital health projects and take a look at what are some of the key challenges and barriers to scale up. I would like to remind all of our participants to please feel free to use the Q&A function on Zoom to submit us some questions throughout the session. And we, of course, will try and address as many of those as possible at the end of the discussion. Without further ado, I would now like to introduce our first guest for today's event, Mr. Ricardo Lamperello. Ricardo holds an MSc in statistics and an MBA. He has 20 years of experience in health, from the pharmaceutical sector to international organizations and international NGOs. In May 2017, he joined Terre des Hommes, where he is the head of the health division. Terre des Hommes is the Swiss leading child relief agency, improving millions of children's lives worldwide with a strong focus on innovative and digital solutions. Ricardo, welcome to the series and thank you for taking the time to be with us today. I'll now hand the floor over to you to deliver your presentation. Thank you.
Many thanks, Danny, for the kind introduction. Good morning, good afternoon, good evening, everybody. It's my pleasure to introduce you to IEDA, the integrated e-diagnostic approach. As an example, a rare example of a digital solution at scale in sub-Saharan Africa. IEDA is a digital solution to improve quality of care in rural areas in developing countries by improving the diagnosis and treatment of sick children and strengthen healthcare performance. As you can see in the picture, the healthcare worker is helped by tablet, so by digital tool, to actually consult the sick child. The tool guides the healthcare worker to pose the right questions, not to forget some questions, and then suggests a diagnosis and then a treatment. This is in a nutshell what IEDA is about. Next slide, please. And has been a very long journey. It was actually 10 years ago that it was firstly conceived in 2010. And then probably this is the first real lesson learned, that the scaling doesn't occur overnight. It took almost 12 different major versions, each version which improved the other one, to arrive where we are today. When we started, of course, we started with a good practice. It was needs-driven. It was with the MOH support. Actually, one of the creator was one of the head of a district in Burkina Faso. But it was also a proprietary software. We used to collect data through a USB key, and then so from each different computer. It was the digitalization of a WHO UNICEF protocol, so that was a good thing. And when we arrived in 2014, actually, we had already reached almost half million of consultations in over 100 healthcare facilities. And can you imagine that running around with the USB keys, having a platform that was not so robust? So that was not possible any longer to continue like that. The system was about to implode. And so this is where actually you have to change a gear. At some point, you have to change gear. It's not a proof of concept. It's not a small project any longer. And in 2014, we had to start again almost from the scratch. We changed the software. We used an open source software. We went into a tablet. We work now on a cloud. And then we added a few features. Like, first of all, we made sure that there was an interoperability, and actually, not only that, but the system could nurture the National Health Information System, DHS2. We also worked with the MOH to make sure that the healthcare worker do not need to fill the paper version any longer. So, but the digital version was already good enough. We worked also on a multiple aspects that changed completely the project that was born in 2011 and changed radically in 2014 to make it ready for a large deployment. And that was the start of a successful story in 2014, because then year by year, since 2014, we reach today when IEDA is deployed in over 70% of the country, so 70% of the country. We are in the middle of transferring the tool to the MOH, to the Minister of Health, and the institutionalization of the digital tool is also another prerequisite for scaling. So actually, as of January the 1st, is the Minister of Health that will manage the tool, that will host the data locally. So this is a little bit the story that go from 2011 to today to get to where we are. Another important aspect, next slide, please, is the external evaluation. When in 2014 we started the discussion with the MOH for scaling up the tool, the MOH basically posed two basic questions. The first one is, does it work? because it's very nice, good looking, but does it work? So does it have an impact? And the second question was, how much does it cost? Because you might have something that has an impact, but is it affordable? Is it sustainable? And those two questions were the questions that the London School of Hygiene and Tropical Medicine had to look for in their 3 years evaluation of the tool. They run a 3 years evaluation, which is one of the largest evaluation I've ever seen for a digital health solution. And in end of 2018, the result of evaluation showed that the digital tool provides significant higher quality of care compared to the paper version. And more specifically, it improves diagnosis and treatment of children with a focus on specific focus on the most severe cases. It shows a reduction of antibiotic overprescriptions. And then finally, least but not last, one of the most important points is that that digital actually comes with the important savings. And the London School was able to estimate the savings on about 1.5 million of annual saving for recurrent cost. So this is after the initial investments, maintaining the tool would actually help the MOH to save $1.5 million each year. So thanks to that, so this is where we are today. Next slide, please. So, and this is the beauty of digital, because when digital health works, when it comes to scale, then the numbers actually goes exponentially. Today in our database, we have 3.5 million children, which is more than 50% of the total population of Burkina Faso. There are over 200,000 consultations per month on average. So really scaling, then it becomes, the numbers go up exponentially and the impact is huge. And then finally, today IEDA is deployed also in Mali, in 2 districts, in Niger and in India. And this might be an interesting discussion for another topic. How do you actually export a successful digital tool to another country? But I stop here and I give the floor back to Daniel. Thank you.
Thank you so much, Ricardo. And yeah, I mean, I think I first heard you talk about IEDA around 2 years ago. It never fails to impress me, the job that's been done and the success of the project. I think it's really a great example of how to do digital health well. And you know, that's been proven in your success scaling up within the country of Burkina Faso, but also now, as you say, internationally. I think those messages that you built your program on established guidelines from the likes of WHO, you worked alongside the Ministry of Health from the very start, and now obviously handing over to them. I really think that it's you know, a great example. And I think particularly the evaluation that you highlighted that was done by London School. We discussed, for those who joined last week's session, in great depth some monitoring and evaluation points and how we can do better to make sure that, you know, what we're measuring is actually real impact in terms of health and in terms of, as you mentioned, savings, financial savings as well. So I think it's really encouraging and impressive to see those findings, and look forward to discussing further later in the discussion. I will introduce our next guest for today's episode now. Our next guest is Dale David, who is a social entrepreneur and the co-founder of MyCure, a medical informatics company whose vision is to securely organize medical records that will provide fast, safe, and efficient access to health professionals, enabling them to help and save more lives. He's also founder of another health tech startup, Happy Hub, Dale has also founded two non-profit organizations, Yana Care and Mighty Minds. He is currently a co-director, mentor, and volunteer at Founder Institute, Manila, supporting tech startups in the Philippines. Dale has degrees from Harvard University, University of the Philippines, and De La Salle University. Dale, welcome to the series. Thanks for joining us today, and I'll hand over to you for now to give your presentation. Thank you.
Thank you for the warm intro, Donnie. Good morning, good afternoon, and good evening to everyone. This is Yana. Yana is a lively, spirited, beautiful 17-year-old teenager. She was set to play for the women's football team in Ateneo. It's one of the top universities here in the Philippines. And like any other normal teenager, Yana loves navigating the social media, dress up like Kylie Jenner, and go out to clubs with her squad. Next slide, please. However, on March 20, Yana got sick. During the March lockdown, Yana started experiencing numbness on her toes, weaknesses in her right arm, then her left leg, and eventually spreading to her entire body. So she was brought to a private hospital. At first, it was thought to be encephalitis, but the doctors cannot properly diagnose her illness. So she was transferred to a state hospital to see a doctor specialist, then another hospital for further tests. She eventually got positive with COVID-19, and with the ongoing pandemic, she was again forced to transfer to another hospital. Next slide, please. Her condition improved initially, but sadly on July 23, 2020, she peacefully passed away. Next slide, please. Before that. Okay, so Yana's dad is actually a good friend and a classmate in grad school. He and his family are, of course, devastated by this. But at the same time, we got to talk about how dysfunctional the healthcare system is in the country. So I shared him that we've been doing tech solutions in the healthcare sector in the last 5 years. So after a long talk, we thought of actively involving ourselves deeply in this advocacy in honor of Yana. Somehow, we knew that improving the healthcare integration would save lives and help avoid unfortunate incidents similar to what happened to her. Okay. So we started Yana Care Health Initiative. It's a nonprofit advocacy to help address the healthcare integration challenges in the country. In partnership with MyCure and Happy Hub, these are the two of the solutions my team has been developing for the last 5 years. Next slide, please. See, there are thousands of health facilities from government and private hospitals, private clinics, rural health stations, pharmacies, HMOs, municipal health stations, and diagnostic centers. All of them use different digital health systems or electronic medical records. Some use old legacy systems, and some don't even have any digital systems at all. Next slide, please. So this results to a bigger problem: integration and interoperability. So while there are good digital health system providers around, there are still data portability challenges. Say if a patient goes to one health facility, it would be difficult for her to bring her medical records to another facility that is using another system. So even with all the technologies available now, a patient still have very limited in accessing her medical records. In terms of social media, for example, a user now has Facebook, Twitter, Instagram to store one's social digital life. They have advanced so much, and yet for one's medical records, which is equally, if not more important, there is no app to easily integrate medical history and records. If this is not resolved, then scaling up remains a huge challenge. If we want to scale, we need to think about integration and interoperability. Next slide, please. So to address this concern, we developed two major products in the last 5 years. The MyCure Healthcare Information System and Happy Hub, short for Healthcare API Hub. MyCure has comprehensive modules like EMR, registration, billing, to name a few, but more importantly, it is very flexible, customizable, and can be integrated with other systems. Now, what makes it really unique is the sync-based technology we integrated in the system. While MyCure is cloud-based, it can still function in the local network across multiple devices, even if the internet goes down. This is very useful, especially in the far-flung areas where internet could be a challenge. MyCure works online and offline. Now going to Happy Hub, on the other hand, it acts as a middleware or integrator. It is system agnostic, so regardless of the system that one health facility is using, it can be integrated and allows interoperability. It has well-documented APIs for easy implementation. It also makes one system secure and compliant by using the Happy Hub platform. It is designed to help scale by integration. Next slide, please. So going back to this diagram, the different facilities can be using different health systems or EMR, electronic medical records. Some may use MyCure as well, but the point is, regardless of the systems that they use, they can be integrated and allows interoperability through Happy Hub. The hub can be managed by a local government or national, like the Department of Health. So they would have full control and management of the platform. Central to Hub's design is the security and privacy, such that personal identifiable information or PIIs remain in the respected health facilities and only transmitted if authorized by the patients themselves. In addition, there are many layers of security and protocols, controls integrated in the processes. Happy Hub only pulls non-PII data that can be helpful and insightful for policymaking and planning. Next slide, please. So the ultimate beneficiary, prior to that, please. The ultimate beneficiary would be the patient, as this setup becomes patient-centric. The patient technically has the right to his medical records and should have the power to authorize and or bring with him the records to wherever the facility he wishes. This setup would also allow a patient portal where the patient can have centralized storage of all his medical records from different health facilities and doctors. Next slide, please. Currently, we are offering MyCure and Happy Hub to the local government units through Yana Care initiative at significantly reduced rates. We have waived the license fees so it will be affordable for them to implement the system. So to conclude, the key is not to force changes in existing systems, but to create a platform flexible enough to integrate one to another and make them interoperable. This way, we are not trying to redo concepts every time, but also able to capitalize on the already existing ones. This is one great way to scale. Thank you.
Thank you very much, Dale, and a great example there of helping to increase scale in areas where there are existing digital health projects. I think we heard an example from Ricardo. The ADA system kind of revolutionized the health system in Burkina Faso. But for your presentation, you mentioned the ways that we can actually use existing infrastructure and make it work better. And thank you for sharing that touching story with us as well, that sadly demonstrates the challenge that we're facing. And also, I think you raised a very interesting point about interoperability, which we've heard several times during this series so far, and it's often at the root of many problems caused in digital health, a lack of interoperability. And also, I think you kind of alluded to there why that is, and why the health sector in particular is so far behind other sectors in terms of its interoperability of data. And perhaps we can drill a bit deeper into that subject later on in the discussion. For now, I'd like to introduce our third guest for the session, Dr. Rafi Mofori. Rafi is a special assistant to the director at the University of the Philippines, the University of Philippines General Hospital, clinical associate professor at the Department of Clinical Epidemiology, University of Philippines College of Medicine, and assistant program leader, for Philippine primary care studies. His research as part of this multifunctional team implements primary care system strengthening in virtually all health system building blocks in urban, rural, and remote settings, including the development of fit-for-purpose electronic health records. His work further aims to bridge public and private spheres to enhance and integrate health systems for equitable access to person-centered healthcare. He obtained a medical degree from the University of Philippines and his Master of Public Health degree from the University of Melbourne. Rafi, welcome to the series. The floor is yours to give us some opening remarks and to share some of your experiences with scale-up challenges in the Philippines.
Thank you, Danny, and good afternoon, good evening, and good morning to everyone. Thank you for having us here. I just wanted to share kind of a story, two stories actually. One would be, I would come out and say that it's a failure of scale up, despite all the strategies behind it. And yet the same software in the second story is quite a success in scaling up. And over the past week, some of the work I've been doing is to just seal up the paperwork to facilitate the partnership, the trademark, the copywriting, and so on, so that we can actually go to market with this. And there's been such a strong response before COVID, and now as we've repackaged even stronger after COVID to address health system challenges that we've aligned with the universal healthcare law with in order to address, largely through this electronic health records that we've made. So maybe I'll just set the stage a bit with the universal healthcare law, and then I'll introduce sort of different characters in this story that you will see interact to scale up or not. I'll start with the universal healthcare law in the Philippines. We're quite proud of it. It hasn't had a chance to prove itself yet because it was passed in February last year and the implementing rules were in October last year. And so just as we were about to roll out, it was interrupted by the pandemic. But the important features of this law are that it espouses healthcare provider networks, primary care provider networks, and these can be public and private facilities stitched together, joined up, as we would like to say in integration speak, so that the experience of patients is seamless, is coherent, and is more patient-centric rather than the patient adjusting to the various facilities, various specialists. And primary care being central, like a platform to all of that, which is quite weak in the Philippines, which is why our research that produced the electronic health records that we think can really help with UHC is a primary care research study. And that brings me to the second, well, I suppose the first main character here would be Philippine Primary Care Studies. It's a University of the Philippines research group, but it's funded by UP, the Department of Health, and PhilHealth. And what we do is to implement a set of enhancements for health systems, ranging from the financing arrangements to some of the governance and tweaks to the health human resource management and deployments and rules and teamwork. And we train them also clinically and functionally for teamwork and for endorsements. We've fixed up transportation subsidies for patients where we know that the main complaint is fares, travel fares for access. And so it's a multi-systemic thing, all the building blocks practically. And we've noticed that these building blocks converge on electronic health records, especially when you go to that aspect of the UHC law that says a patient should be able to get kind of a prescription at the public health center. And if the pharmacy doesn't have that drug anymore because of all these problems with supply chain in the public sector, then maybe that patient can go outside to a neighboring pharmacy that's part of this network and get it dispensed there. and the system can track that, and the system can pay for that authentically, accurately, efficiently, without out of pocket for the patient. So that's kind of our research that gave rise to all these wonderful features that I won't go into great detail about, except to say that we fit these features to the workflow. We designed them to maximize local resources, like having, for example, only one doctor for 30,000 people. And that kind of a public health team usually relies on nurses and health workers, midwives below the doctor level as a team. So we have features like those non-licensed or not licensed to prescribe being able to propose a prescription on our system, which is then seen real time and approved by the doctor. And so it's like having the doctor's presence even in the village centers. So that's just an example of how we think about it and what it is we're trying to scale. So great features, very, I think, responsive to the needs. And I think that is one thing I would credit its success in scaling up to in the provinces, in the local governments. But just to fast forward to the other character in this story where we begin to see the difficulties of scaling up was our own university hospital, the Philippine General Hospital. Some of the salient features here are that we have a lot of legacy software. It's a very fragmented system, various departments. This is both a positive and a negative quality, that there's this independence, there's this initiative to build their own systems. And so surgery has its information system, pediatrics has its own, and it's become quite fragmented in terms of platforms and little kingdoms. One in particular, software was created by someone who has some administrative authority at the hospital, and managed to work this into the administrative issuances, saying you must use this software. And so it's perceived as a sort of requirement. Nonetheless, one more feature is that the university seemed to not really have a conclusive answer to whether it would build or buy. So all this, if we're familiar with build versus buy, all this building or homegrown software was going on all these years, without, I think, the sufficient backing in terms of budget and manpower to really make that the system. And so in recent years, we've started looking at off-the-shelf proposals and starting to select some as maybe the strategy to really accelerate computerization of the hospital. And so going back to the research, where our EHR would have fit in the hospital was very strategized, I think, in particular by forming a partnership with what eventually became the winning bidder or proposal to computerize the hospital, because the partner is actually a government entity as well, and so that takes care of a lot of the red tape. But they are backed by a private IT company that is subserving this government entity that's producing the aid for hospital computer systems. So you have this nimbleness and this pool of talent behind a package that is very government friendly. Plus, we are a government university, so it was a wonderful partnership, so many synergies. In particular, our software was designed in the research for outpatient settings, and so it would have been perfect for the outpatient department of our hospital. Again, fitting the needs. That department is also some of the most neglected areas in the hospital because, of course, with inpatient care, until recently, attracting all the money, all the attention, all the specialization, you kind of have a lag with outpatient developments. So this partner was actually looking for an EHR development expert. They wanted medical experts, and in the Philippines, the Philippine General Hospital is highly regarded for that. And so it seemed like a beautiful synergy. And we were able to leverage that and say, in one package, you could have the hospital info systems and an outgrowth of that where they would develop further our software with their more empowered IT machinery, because they have the development capability for that. Whereas we were just a research group hiring a couple of programmers on and off, depending on our budget. So right there, you have one lesson for scale up, I think, which is specialize. R&D has its advantages. There's a lot of freedom. There's a lot of basing on the best literature, best experiences around the world. But when it comes down to pushing from R&D into, leading the market or producing the product, rolling out to scale, you start to think about the capability to do so, like covering all bases, removing all the bugs, adding the necessary features, getting all the regulatory permits. And a company that's used to that from the hospital side was a great ally, and it continues to be in the second half of the story. So this partner offered a wonderful HIS, or hospital info system. They have a great track record of uplifting government hospitals with their system, because their system doesn't just do software. They also bring in the hardware and, if necessary, a bit of IT infrastructure for the hospital, and most crucially, business process improvements. So they analyze what's going on with the processes, the back end, billing and so forth, charging to the government. And because they make these efficiencies more real to the hospital through their system, plus hardware and so on, and training, the hospitals that become their clients, their income just skyrockets from government social health insurance. So it really positions the electronic systems as just a tool to the bigger systems that enable healthcare, including the outpouring of funds and the accomplishment of records themselves. So that was really a great ally to bring aboard. So going to the strategies for how our EHR would have gone to the hospital, I would name perhaps 4. I mentioned the legacy systems and fragmented platforms. Our plan was to essentially, in a single word, copy them, because there's no way that we would have created interoperability among several systems when we're just a hospital. Our IT department is quite limited. We're not an IT company, and to devote all our energies to so many interoperability efforts among platforms of varying ages and languages and purposes and proponents, the best solution was kind of a hybrid. And I think that's strategy number 2, which I think is an overall strategy. The hybrid solution would have been both a build and a buy. Because for the hospital admin side, it would have been a buy, but it retained control of our expertise to determine how to then develop that, because they, the partner that we were signing on, would also want to build their system better. And so we had some leverage as the medical experts saying, you must design the system like this. We want features like this. Could you change that? So a hybrid system was such a blessing. It was difficult to engineer, but when I spotted the opportunity, it sold pretty well. My boss, the director of the hospital, jumped on board, saw the advantages. The head of the IT office, who herself was going through the HR aspect of it, beefing up capability, motivating her people, assigning tasks all the time, getting things up and running. That was her plan too, to have some component of the security of a company, that the professional IT company behind that, at the same time giving our doctors a voice. So that's the hybrid model. As for that one particular fragment, or its proponent rather, who was also an administrator, technically a lesser ranking administrator than my office or my boss's office, because my boss is the director. But we're very nice people, and so we don't want to bulldoze anybody. So this guy's memos went out to please use his system rather, for particularly the inpatient parts. So our strategy number 3 was actually to really, you see how interoperability minded we are. Our strategy number 3 was to piece together a system where we would sort of share the pie. So he made a lot of progress in inpatient clinical side. We made a lot of progress in outpatient clinical side. Maybe we could interoperate that. And then for the administrative side, for the PhilHealth and the management stuff, that we assign to the partner. And so you have kind of a three-way set going on there. But because this person wasn't as probably collaborative minded as we were, he actually refused to lead. We actually offered the leadership position. And here you see our attempt to have more of the social side. So we were looking at stakeholder engagement, mapping out the interests and so on. And we said, well, this guy was, quite experienced, knows the ins and outs of the hospital. So we said, maybe let's make him the leader of this three-way effort. He'd be on top of the IT office. He'd be liaising with the partner, and we would even subsume our system at the outpatient department under his leadership, and that would get the buy-in and secure, allay his fears of his system being demolished, because he's in command. But surprisingly, this person refused, and so began the failure of the scale up here. So when by the time COVID pandemic struck, we were in a position where we thought our system could really help, and so we pushed for it to be installed in the various clinics in the outpatient department. Telehealth was becoming important because people weren't coming to the hospital, and it was important to see them over distance. And our system was great at that. We proved that in our outside implementations, municipality-wide implementations. But instead of being able to compare, the users in our hospital would only see our system in one department because the memos and so on and this person's resistance continued to just implement his system, although to be quite frank, it was less developed in many areas for outpatient care. So we have just pulled out of the hospital in that sense, and focusing our efforts now on the local government implementations, where it has been much more receptive, much more welcoming. In fact, I would say that our strategy was to have been compared out of merit. But I think the existing system won out of administrative enforcement, and rather than rock the boat, especially at a time when the hospital was undergoing a lot of change because of COVID related changes and arrangements, we said, look, these departments have enough on their plate. Let's just let them use whatever system they are comfortable with at the moment. Maybe it would have been a better time some other season. So we would focus our efforts now on implementing among the local governments. And so I'm going back to the research now where, as mentioned in the intro, we've implemented in urban, rural, and remote areas. And to start off with the most advanced site in terms of scale up, we started in a municipality there, and now they're moving towards province-wide implementation. So we're in the city, we're in several facilities. And aside from that province, we've been sort of sharing our results because it's research. We've been sharing and presenting to governors, to provincial health officers, who are the key people that must make the decisions on what system to use. We and the partner have held forums. We've activated our networks and shown all the advantages of our systems, aligned with the UHC law, which by itself is mobilizing them on the governance side. So we come in very compatibly on the health IT side. And here we have a separate set of strategies. I think the forum and the targeted communications are one. We've also recently, I mentioned, upgraded, and this is the second strategy, I think is a great full package. We give the software, the training, hardware, spare hardware, so that in case of repairs, service is uninterrupted. We even put in the internet connectivity infrastructure. Maybe it could be Wi-Fi. Sorry, I'm not a tech person, but you have galvanized poles that are capable of withstanding the storms here in the Philippines, and you mount transmitter receivers over great distances, or you could have satellite uplinks to internet service from the satellites. And we also include loan financing, which is very important now as budgets are contracting because economies have slowed down due to COVID-19. So again, as ever, as we've always done, we get a reading of where we're going and we try to develop a package and an approach that is compatible, likable, and meets their needs. And I think I'll end with the third one, which is, so you have the forum and the targeted communications. We even tweak them for whether it's a governor or a doctor or a health officer. Second is the end-to-end package. And third, I think, is the partnership itself. Because the partnership itself allowed us to specialize. So we as doctors can focus on the design of the features and the alignment with the policy, which our research also shapes. And they, as the partner, they get to think about things like how much will it cost, and how to keep this affordable, and how to deploy quickly, and that's in the completely without compromising quality over distance, because we're talking to different provinces all over the Philippines all the time. So it's been, I guess as a recap, it's been two different stories in our own backyard, lots of complexities, social complexities, no shortage of strategies for scale up on our part, maybe an underestimation of the attachment of some people to their pet projects. But on the other hand, the same strategies of addressing people's needs is working outside. We have several calls and meetings lined up before and now after COVID to scale up and to implement. So lots of different strategies there. So over to you, Danny.
Thank you, Rafi, and thanks for sharing your experience, giving us some really good examples of the work that you've been doing in the Philippines. I think it's always, it makes you very aware of the challenges when you see the struggles you have just to provide an interoperable system within one hospital, and then you realize the challenge we face, at a national level or even a local level. But as you say, it's kind of encouraging in a way that the same problems, have solutions that work in different ways in both settings. I also, thanks for reiterating the point again that COVID has been an important catalyst for a lot of digital health strategies. And although it's been an awful experience and is an ongoing awful experience for many people, at least that's one positive thing that we can take away from the whole pandemic. Okay, I will transition now into a brief discussion portion of today's session. And I'll start by coming back to Ricardo as our first speaker. Obviously, this will be a kind of project-specific point to some extent, but generally in your extensive experience with digital health projects, who are some of the key stakeholders to engage and mobilize for enabling scalability, and how do we incentivize these various stakeholders to ensure progress?
Thanks, Danny, for the question. And actually, it's good that you talk about stakeholders, because I think when we talk about scaling, there is, of course, a lot of literature, guidelines, international guidelines, and the role of human factors and the role of stakeholders, I think, is often oversighted or even neglected. But I think the focus is often on the technological part and very little on the stakeholders. Whereas actually the IEDA experience shows that the stakeholders, first of all, there is a vast network of stakeholders involved. We think about users as the main stakeholders, but there's also child caregivers, there is the head of districts, there is the Ministry of Health, and within the Ministry of Health, actually, there are many directorates. So the number of stakeholders is very large, and each of them can actually block or actually incentivize the digital solution. So I think it's very important to put in place a strategy how to address each single stakeholder, and how actually transform stakeholders in an ambassador, in champions of the digital tool. And I'll give you a couple of examples. For example, before deploying the tool in the communities, we used to run an awareness campaign, so that actually the community becomes familiar with the digital tool, with something new. We try to address the doubts, the resistance. So after that, it's interesting to see that when the child caregiver brings the child to the consultation and doesn't see the healthcare worker taking the tablets to help doing the consultation, actually is the child caregiver himself or herself that actually ask for the tablet to be used. So it is very important for the adherence, the adoption of the tool in the community. We see a lot of healthcare facilities with the tablets that never be used. So how do you make sure that the tablets are actually used in the middle of nowhere when there is no TV staff? This is a strong incentive. Another one is in the head of districts. So the head of district objective is the performance of the clinics in their districts. So we collect data, and we decide that we should also support the head of district to make a better job. So new features were added, like graphs of the performance of healthcare workers compared to other healthcare workers. There were all the statistics by each clinic, by clinic, and by healthcare worker. So this would help the head of district to monitor what is happening in that district. Doing that, actually, you gain the engagement of the head of district. And as you know, the head of district in many of these countries tend to change continuously. In Burkina Faso, almost every other year, they move to another district and in another region. So they virtually become a sort of ambassador of the digital tool, because if they think that is useful for them, in the region where they go, in the new district where they start working, they would actually put pressure at the central level for the tool to be deployed and used also in the districts. And then last but not least, as I said, the users. The user, is very important that the users see an advantage in using the digital tool. Their daily life is always packed. The routine they have so much work. So if the digital tool represents an additional burden on their packed daily life, they will not use it, even if it's a compulsory. They will find a creative solution not to use it. So I think so. And how do you make sure that it is actually an addition? It supports the tool, supports their daily life. So what we've seen for IEDA, what really helps the healthcare worker is the monthly reporting. Because when you start, the digitalization brings all the data collection and then the monthly reporting, a matter of few clicks. You collect data day by day, consultation by consultation. And then we make sure that all this data is nicely, seamlessly integrated into the national, regional, and district reporting systems. So who likes to edit reports at the end of the month? Nobody. So this is actually a strong incentives for them to use the tablet, because they know that at the end of the month, the reporting time will be dramatically reduced. So, and I think I stop here. Have other examples of the importance to incentivize stakeholders. But I think the overall idea is that we think about interoperability, we think about many technicalities, but also the human factors cannot be underestimated. It's so important for the scaling and wide adoption.
Mm-hmm. No, it's an excellent closing point. I think that's something, particularly if you're coming from the tech side of things, that we often forget. We worry about the challenges of interoperability and data, with privacy of the data, rules and regulations around it, but we forget that health is human-centric and it should remain human-centric. And that means considering the people that not only benefit, but also that benefit from these interventions, but also that facilitate them. And obviously the users of these tablets are a key one in your example. And I think, yeah, the only way to really get their buy-in is by making their lives easier through the use of these tablets, not by adding more work for them. Dale, I'll come to you for a next question. I'm very aware that we're running out of time quickly, which is always the case with these discussions, but I will squeeze in a question with you and a final one with Rafi. I think that your concluding message at the end of your presentation, that the answer to scale up in some scenarios, and I think actually nowadays it's most scenarios, especially where there are existing digital health systems, is integrating these systems and not trying to reinvent the wheel and create a whole new system from scratch. However, it's obviously easier said than done. So if you can, in just a few words, perhaps outline what are the first key steps that need to be taken in order to begin to integrate health systems at either a national or local level.
Sure. Yeah, it remains a big challenge, interoperability and integration. But right now, different system providers are creating their own, systems. Health facilities create their own systems. So that's when the problems compound. The idea here is creating an integrator, a middleware, so that regardless of the systems that health facilities are using, it is system agnostic, so that everyone can actually integrate and interoperate with one another. So that's the idea of what we created with Happy Hub. It's a platform. It's neutral. It doesn't say I want to use the system or that. It's all API based, so that anyone can just connect. Just looking at the documentation, anyone can integrate in the platform and able to interoperate with other systems as well.
Excellent, thank you. And one, I think we have time to ask Rafi one question before we wrap up. So obviously you've mentioned just to, in some detail, the challenges implementing a hospital-wide electronic record system. What are the challenges that, the new challenges that arrive when you try and take this national, and even thinking bigger than that, will you ever see a time when electronic health records will be even international, and maybe one day we carry an e-health passport with us to be able to take our data with us, our health data with us, and wherever we go, we'll have our records there ready to integrate into the local healthcare system?
Wouldn't that be the ideal, actually? And what we're seeing is, in some ways, the health sector, because we're trying to push for something that everyone must access as a right, is a catalyst. For example, the question has been raised about the national ID system maybe taking off from our universal healthcare, but that's just to your point about someday, seeing this spiral off into something. But as to the challenges in the hospital, and I think Ricardo and Dale have both started hinting at this, if not explaining it quite well. I just want to add, aside from the technical stuff, we are hearing something about COVID catalyzing something with the word bus in it, that all electronic records must be able to communicate with this central kind of, I know it as a dictionary, an information exchange, I guess, to the technical point that Dale mentioned. And then addressing the real needs and targeting the stakeholders, as Ricardo was saying. I think those are both very important. Aside from that, being sensitive really and showing your sincerity to that you are there to solve problems. That, you know, one thing that we haven't let go of is we wanted our software to be under the name of the university, because then it would be undoubtedly, it's not, you know, we're not doing this for profit. We're doing this to solve problems, your problems, our problems. We are one of you. I haven't mentioned how, just to show how deeply knowledge of your target market and your target scale domain can go. One example is our choice to be a government offering is huge in the Philippines, because our bidding system, like any public procurement system perhaps, is just such a big headache. And can you imagine if a governor or a mayor had to bid out and plan simultaneously with the risk of failed bids, failed procurements that cost you months, all of those components, you know, the hardware, the infrastructure, the training, everything, the maintenance, the repairs, the software licensing itself, to package all that with what in our laws, in our legal structure, allows for what you call negotiated procurement, means you don't have to bid. Because we are presumably above board, and you know, in the same boat as them. We're not trying to get their money. It's a government project helping other government institutions. And I think just to show the depths of stakeholder engagement and having a good read on the market. Then you have your larger, if you go upwards here, you take the elevator all the way up to the structural dynamics, like in our case, the Universal Healthcare Law. It has specific provisions requiring electronic health records, to the point that it actually says the Department of Health and the Social Health Insurance Agency, PhilHealth, must come out with so and so and so. And so on the side, we are talking to them on certain parts of those, saying we'd like to help, you know, whether you take just the lessons we've learned or the actual software we've made. And what's happening, and fingers crossed here, slowly, little by little, you know, that sincerity is shining through, and I think we're starting to see each other on the same side of the battle here. For example, we've made headway with our partner being so enthusiastic and so capable. They've made a separate package, a product really. It's called a PhilHealth member registration form. All it does is really help the health worker register quickly. You know, you cut it down by half the time, and this is time that you're paying for on a salary basis as a government, and that is time taken away from healthcare. Yeah. And the registration is crucial because the funding under Universal Healthcare Law is per head. Yeah. If this person isn't registered to your province, your budget diminishes. We are juggling all of these aspects and saying we've read it, we're in the same boat as you, and we design solutions that address your needs. So it's.
Yeah, no, I think it's an excellent point, and you know, that relates as well to the point Ricardo made about making sure that it improves the situation for everyone, and especially the healthcare workers. Unfortunately, we do have to end there. So I would like to thank all of our speakers for today's session, of course, as always, my colleagues here at UNITAR as well. And finally, a big thank you to all of our participants for joining us today. Over the past 6 weeks, we've explored some of the biggest challenges to the advancement of digital health, and I've been lucky enough to be joined by some truly internationally renowned experts dialing in from around the world. And here's where I thank specifically Dale and Rafi, because I know it's extremely late where you both are. So thank you very much for taking your evenings to be with us. I hope that as participants as well, you have found the discussions interesting and engaging. We'd happily receive your feedback over the coming days. And with that, it's time to end this session, but also indeed this short series as well. Sincere thanks again to all of our speakers and participants, and wish you all a very pleasant day. Goodbye.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.